Thank you for joining us this evening for SCAI's roundtable discussion of some of the top research presented at the recent ACC 2021 scientific sessions. I'm David Cox, SCAI past president and chair of the SCAI Communications Committee. And this evening, I have a few members from our committee who have joined me to discuss what we believe are some of the top interventional cardiology presentations from last week's meeting. I'm joined by Kurt Garrett, my chair of SCAI Committee, Luai Tabaza, Drew Klein, Mike Savage, and Gary Ledley. So we have a lot to cover, so we'll go quickly. First, we have sex-specific outcomes in high-risk patients receiving ticagrelor with and without aspirin after PCI. Results from the TWILIGHT Trial. Luai, can you walk us through this?
Sure, thanks, David. It's great to be here. And the first trial here we're going to talk about is the sub-analysis of the TWILIGHT trial that looked at, it was a double-blinded trial that looked at monotherapy with ticagrelor after 3 months of dual antiplatelet therapy versus continued dual antiplatelet therapy as far as bleeding risk and ischemic risk. This trial was led by Dr. Roxana Meron and team. And the new analysis looked at the sex-specific differences in this high-risk population and analyzed both two parts. They analyzed and compared the differences between men and women as far as the baseline characteristics, and they compared also the treatment options in the trial between men and women. Tim, can you move forward, please? That's what I just mentioned, so we keep going. So both treatment groups here received dual antiplatelet therapy, as I said, for 3 months, followed by ticagrelor and placebo in one arm and ticagrelor and aspirin in the other arm. There was approximately 2,700 men in each arm with about 850 women in each arm. Randomization happened after the end of the 3 months period, and patients were followed for 15 months. As I said, they looked at high-risk patients, so they defined that as both clinical and angiographic criteria, including age above 65, female sex, troponin, diabetes, CKD as some of the clinical, as well as the presence of PAD. For angiographic criteria, multivessel CAD, target lesion requiring stenting, thrombotic target lesions, bifurcation, left main, and calcified lesions. So these were true high-risk patients. The initial trial was not broken down by sex. However, it did include enough of data here to do a sub-analysis. Endpoints included were primarily BARC bleeding types 2, 3, and 5 at the time between 0 and 12 months post-randomization, and the primary ischemic endpoint was all-cause death, MI, and stroke in the same period. They did a different analyses. Obviously, this was a Kaplan-Meier, and hazard ratio was defined as 95% confidence interval. The first part where they compared the baseline characteristics, this was something that we've seen before in a few of the other trials that looked at this. Females or women had were older in age at the time of the event. They had more comorbidities, including diabetes, CKD, anemia, hypertension, compared to men. However, men had more history of MI and had history of coronary disease, more coronary disease compared to women, as well as higher smoking rates. Next. That's what I just mentioned about bypass surgery as well. Next, please. So the analysis looking just as at the baseline characteristics showed that there is a lower bleeding risk in men compared to women. Obviously, the ischemic events. Next, please. And that was across all categories without differences. Women were at higher risk for, as I said, for all types of bleeding, regardless of the score was used. Ischemic risks were not any different between the two groups, including death, MI, and stroke at 1 year. Now, yeah, and that's essentially what the data showed were not significant. Next. Now, when they adjusted for the differences between the two sexes at baseline, as far as baseline characteristics, those differences in bleeding were not there anymore, or were not clinical, were not significant, statistically significant anymore. Next. Bleeding risk, generally speaking, had a tendency to be higher in women without a clinical significant, without a statistically significant difference. Next. And this is what I just mentioned. When they looked at the two arms of the study, where they compared the treatment modalities between men and women in the treatment arms, there was no statistically significant difference in bleeding or ischemic risks. However, there was one notable difference, which was lower risk of mortality in men compared to women in the ticagrelor monotherapy arm. Next. And that's here what is seen in this graph. So as I said, that was a low number. So we're looking at numbers of 2 versus 9. And that's hard to be able to build on just by this, but it can be something we should look into, and a signal that would tell us that maybe women would potentially do better with the monotherapy after short TAPT, and would require further studying. Next. So the study obviously had its limitations between the two groups. This randomization was not stratified by sex, so the numbers we're looking at were low for events, obviously 2, and that can be a limitation here. So they concluded that women had a higher bleeding risk compared to men, mostly attributed to baseline differences. Ischemic events were similar between sexes. In high-risk PCI population, the benefits of early versus continuation, withdrawal versus continuation of ticagrelor were comparable between men and women, and these findings motivate dedicated studies to look further into specifically withdrawal of aspirin early in women to see if there's any true mortality benefit to that.
Great, Luai, thanks for that summary. Couple questions for you, but I think if you don't mind, let's get through everybody else's talk, and then we can kind of come on back and have a roundtable discussion, if that's okay.
Sure.
All right. Next up is Michael Savage. Mike's from Jefferson, and he's going to talk about the FLOWER trial. Mike, you up?
Hey, David. Everybody see this screen okay?
We can see the screen. We don't see the slides yet, Mike. We can see a whole bunch of slides.
Okay.
There you go.
Is that up okay?
Perfect, Mike.
Okay, great. So, so we're going to review the FLOWER MI trial, which I think is really a groundbreaking trial. This trial kind of piggybacks on a number of studies that have looked at the benefit of complete revascularization in STEMI patients. And I think that's well accepted now as kind of standard practice that patients with STEMI undergo revascularization of non-culprit vessels soon after their STEMI intervention. And what the FLOWER MI trial looked at was what is the best way of judging which non-culprit lesions to intervene on. So this was a randomized comparison of angiographic guidance versus FFR guidance, kind of taking its clue from the FAME trial. And this presentation at the ACC was accompanied by simultaneous publication in the New England Journal article. This was from French investigators from 41 centers in France. It was a study of 1,171 patients who had STEMIs that were successfully treated for the culprit lesion, and then had multivessel disease with at least one additional vessel felt amenable to PCI. They were then randomized to complete revascularization with angiographic guidance during the index hospital admission, or in one-to-one fashion to complete revascularization with FFR guidance, again during the hospital admission. The investigators were encouraged to do the non-culprit lesion at the same sitting, but it turns out that more than 95% of patients were treated in a staged fashion with a median of 2 days after their STEMI presentation. Now, the primary outcome was a composite of all-cause mortality, of non-fatal MI, or unplanned hospitalization with urgent revascularization during the first year. The inclusion criteria, obviously these were STEMI patients, adult patients. They had to have a successful culprit lesion PCI done, and they had to have at least a 50% stenosis in an amenable to PCI lesion in a non-culprit vessel. The major exclusion criteria were cardiogenic shock, prior coronary bypass surgery, extremely tortuous calcified vessels or CTO, patients with single vessel disease, obviously, and patients with multivessel disease referred to surgery. These were the major patients who were excluded. And here's the primary endpoint data. This is shown as a percent of patients without a primary outcome, which again included death, MI, or urgent hospitalization requiring revascularization. And as you can see by the hazard ratios, there was no significant difference between the angiographic-guided group or the FFR-guided group. In the FFR-guided group, the outcome event rate at 1 year was 5.5% versus 4.2% in the angiographically guided group. In addition, there was no major difference between the individual outcomes. There was no difference in death, no difference in non-fatal MI, no difference in urgent hospitalization requiring revascularization between the two groups. The only significant difference that turned out between angiographic guidance and FFR guidance was cost. It turns out that angiographic guidance was more cost effective due to the cost of the FFR technology. So I did a little bit of quick math looking at how this would have translated at our institution. And so if we then took an FFR approach where you're using a pressure wire in every case, that obviously adds to the costs. The FFR guided group on average had a 0.5, meaning half of a stent less utilization per procedure. So if we take into account those two costs, here at Jeff, we would say that FFR guidance would add a little over $300 to the cost of an individual procedure. So that was the only significant difference between these two strategies. So the conclusions of the investigators was that in patients presenting with STEMI and multivessel disease, treated with multivessel revascularization during the index hospitalization, first is that the event rates of MACE at 1 year were low. They were roughly about 5%. For non-culprit lesion revascularization, investigators' preference is a staged procedure, as I mentioned, which was undertaken in more than 95% of cases. FFR-guided PCI of non-infarct-related lesions does not reduce the risk of a composite outcome of death, reinfarction, or urgent revascularization at 1 year compared with an angiographic-guided strategy. And finally, that cost effectiveness and cost utility slightly favor the angiographic-guided approach. So some thoughts for discussion is if we put this in the context of, in contrast to the FAME trial, which was a trial looking at FFR guidance in basically stable ischemic heart disease patients, FFR guidance did not result in superior outcomes. And this suggests that there is a difference in pathophysiology and natural history of non-culprit lesions in STEMI patients, which is different than in lesions with stable ischemic heart disease. And this, I think, makes some intuitive sense based on the prior literature. We do know that in acute coronary syndrome patients, it's not uncommon to have more than one unstable ruptured plaque. It's not uncommon to have a high frequency of vulnerable plaques characterized by thin cap fibroatheroma or TICFA. And therefore, perhaps these lesions, which may not be flow limiting by a physiologic assessment, may still be vulnerable to clinical events and may benefit by preemptive intervention. Another important aspect is that the expected event rates that led to the power calculations was a 15% rate in the angiographic group, but the study event rates were only in the 5% range. Therefore, in retrospect, the trial was significantly underpowered to show a difference. In only about a third of patients in the FFR group, they did not have PCI, and that indicates that most of the non-culprit lesions were physiologically significant. So this raises the issue of would a more relevant study of be to take patients that had non-culprit FFR of greater than 0.80, comparing a PCI versus no PCI approach. And this was the approach done in the kind of seminal DEFER trial, looking at in patients with stable ischemic disease. And finally, this last caveat leads to the question, which I'd be interested in discussion, could there still be a role for a hybrid approach? Keep in mind that in the COMPLETE trial, which was really the granddaddy trial in this arena, that the criteria for revascularization required a stenosis angiographically of at least 70%, but for more intermediate lesions of 50 to 69%, an FFR to qualify had to be less than 0.80. And I must say that this COMPLETE approach has personally been one that I have often adopted, and I'm not sure that the FLOWER-MI trial necessarily changes that, because it doesn't address this kind of hybrid option. So I'll be curious to hear from the opinions of others.
Great, Mike. Those are excellent points. Really seminal trial that we all got to try and get our arms around. So moving on, I'm going to ask Drew Klein from Piedmont to go over the SAFE PAD trial. Drew?
Perfect. Thank you, David. I greatly appreciate the opportunity to present here today the SAFE PAD trial, and specifically, I'll give you the, as I call it, the idiot's guide to the SAFE PAD trial. There's a lot of masters of public health and statistics that went behind this, kind of dumb them down. I had to go look up a lot for this, and so no conflicts of interest. Next slide, please. Our target today is to really translate this study into clinical perspective. Next slide, please. And the study, again, was an initial report from the SAFE PAD a study looking at the safety of femoropopliteal endovascular therapy using drug-coated, specifically Paclitaxel-Coated devices. So drug stents and the balloons in this, and this is based off of the data saying that there may be an increase in mortality in patients who receive this, and the FDA's mandate following that. Next slide, please. So why should we do this study? Well, the first and foremost is, I think the take home is right there. 2 years, the Katsanos meta-analysis showed a 68% greater mortality risk compared to control therapies, and at 5 years, a 93% greater mortality risk. I pulled this off of a law firm's website. So pay attention. This is actually you're gonna see the same thing you see up here is endovascular specialists being encircled by some sharks and the IVC filter lawsuit issues that have happened. And this is what prompted Eric and the team, Bobby Ye and the group in Boston to do this, is really try to get down to the bottom of what's going on here. Is this signal real? Is there really a mortality increase using these drugs? Because physiologically it doesn't make any sense, considering that paclitaxel can be used in 50 times to 500 times the dose for chemotherapy, and it doesn't cause issues. So it is interesting. Next slide, please. So what has been the fallout from all this studies from the Katsanos meta-analysis? The fallout's very clear. The FDA has responded saying that all of us that do EVT therapy should discuss various different options and document that using paclitaxel-eluting stents or balloons, looking at a favorable risk-benefit ratio. I do advise everyone to look at SCAI's website for this, and I copied and pasted that right into an epic note that I put in all of my discussions with my patients who are going to get endovascular therapy. Next slide. So why don't we just do an RCT? Right? Answer the question. That is the gold standard. That's the pyramid as we talk about it. Here's the problem. An RCT power, when you look at analysis, would be almost 40,000 patients. Next, advance, and that equals too much money. Too much money. So no one's going to pay a $40,000 patient trial in this. Plus, when you're talking about issues of harm, we have some issues with ethics as well. So I think the idea is you're never going to see an RCT in this arena, at least a large one that would be able to answer the question. So we're going to have to rely on our statistical techniques to find other ways. Next slide, please. So the SAFE PAD trial is really focused. It really answers the primary question: are DCDs, or drug-coated devices, used in the FP space non-inferior to non-drug-coated devices in respect to all-cause mortality? That is the question on the table. And then you can look at some sensitivity analysis and some consistent safety profiles. And we'll go a little bit into that. But the question is there a mortality difference? Yes or no? That's what the FDA has suggested there is based on the meta-analysis. We need to know the answer. Next slide, please. So you got a game plan. If you want to delve into the statistics, please read that paper that's in CIRC, Cardiovascular Quality and Outcomes. This is designed with the FDA, pre-specified analysis. We're looking at Medicare fee-for-service beneficiaries greater than 66 years of age. You have a large time period of almost 3 years, and treatment exposure is as follows, and the outcome was mortality up to May 31st of 2020. Next slide. So diving into the plan details, you want to get behind things. There's this thing called inverse probability of treatment weighting. This is one of the 14 acronyms I had to go look up and what this meant. The translation is this: when you start dealing with greater than 100,000 patients, which you'll get to when you're dealing in a Medicare database, p-values generally become clinically significant in things that are not clinically relevant. For instance, between 77.2 years of age and 77.5 years of age. There may be a p-value there that's significant, but it doesn't mean anything. So you really need to try to do something different. And that's why when you're dealing with large databases, you have to use something called IPTW, and that really creates balance groups by weighting patient according to observed characteristics. And then with this weighting, you can then create a non-inferiority design. And then additionally, you can look at subgroup analysis as well. Next slide. So plan a little bit different. I think the key thing is here, this is a retrospective study. And all of us that have ever sat through Journal Club will always say, well, the biggest issue there is confounding. Well, to look at, number one, whether or not if a hospital uses a bunch of DCDs or doesn't use a lot of DCDs, does that make a difference? And then does your model fit? Is your model accurate that you're using here? And that's something you use falsification endpoints, which we'll get into. And then what if we miss something? That was the question. What if they missed a confounder? And so to deal with the largest Achilles heel of retrospective studies, confounding, the authors really did a nice job at tackling this in not just one way or two ways, but three ways. Next slide, please. So who got studied? Some pretty sick people. So 77 years of age, critical ischemia, again, 47% of the population. So just as an aside, when you have critical ischemia, your chance of being dead at 1 year is nearly 25%. So are we surprised that there was mortality increase in these patients at 5 years? Most were smoking. Many have all the usual risk factors. That's why we're in this job. But this is a very, very sick patient population. Next slide. Interesting enough is that it's pretty balanced. And this is, again, this balancing between groups and this thing called standardized mean difference. That essentially means that when you look at it, if you look at SMDs and it's less than 10% amongst the groups, you're actually doing pretty well. And the interesting part is it wasn't balanced with respect to volume, use of atherectomy, or inpatient status. And that may go down to kind of OBLs, et cetera. Next slide, please. Or advance. Yeah, this is the same way of looking at it. This was Eric's slide. Go back one, please. This means the same one, which is basically when you look at all the baseline characteristics, there were only a few things that were outside of that standardized mean difference. So this is just a way to show that your model is actually fitting really, really well. Next slide. Here's the take home. Unweighted, weighted, doesn't matter. We got a weighted difference that is none, zero, no difference in mortality when you actually look at this. 54 versus 55%. A median fall pretty long, almost 2.75 years. Next slide. So this made me laugh because I looked this up and it said instrumental variable analysis is really what they call an orthogonal view. I said that's what I do with the camera when I go another orthogonal view in the cath lab. And when they talk about IVA in the MPH world, they talk about looking at the data in a different way. And this was their way to look at if your center uses a lot of drug-coated balloons or stents versus a center that doesn't use a lot of drug-coated balloons or stents, does that make a difference? And the answer is it doesn't make a difference at all. When you look at the other ends of the spectrum, using the instrument or not using the tool did not make a difference on the data. Next slide. Falsification endpoints. This is a negative control. This is the best way to think about this. If your model doesn't fit or there's something wrong with it, there's going to be a difference with these outcomes. And the take home is this. You don't expect a drug-coated balloon to affect pneumonia rates. So therefore, there should be no difference using a model. Shouldn't affect CHF. There should be no difference in model. Shouldn't affect AMI. No difference in model. So this tells you that the model that they used was in fact legitimate, and your falsification endpoints here essentially tell you that they were spot on and there's no difference. Next slide. And then the last thing is, again, the biggest issue with retrospective studies is there a confounder? What if they missed a confounder? Would it alter the outcome? And essentially, when you look at all the measured variables included in SAFE-PAD, all of them were in that center grouping, which basically tells you that there's no impact there here. Nothing was missed. So there's no missed confounder that would flip the study outcome, which showed no difference in mortality. Next slide. So the drugs are definitely not worse for sure. In fact, they might be a little bit better. The only low risk groups crossed the line, and even then it really still crossed that hazard ratio of 1. No worse, and again, maybe better when you look at all these patients that received, if you look to the left of the line here, favoring drug. So definitely no signal here in 168,000 patients that the drugs made things worse. Next slide. So Eric's conclusions were over 160,000 Medicare beneficiaries. There was no difference in terms of mortality. And because of all those fancy techniques I just showed you, instrumental variable analysis, falsification, missing confounder. And it's consistent in even pre-specified subgroups. My take home is this. You got 160,000 patients versus 800 patients in the COTSINOS meta-analysis. It's a retrospective study, so confounding is the issue. However, some pretty sophisticated techniques were used to address confounding, IVA, falsification, and missing confounder. And these are pretty consistent results now across the spectrum. Next slide, please. So where does this fall in the data range? To the left here is all the meta-analysis. And remember, all the meta-analyses that have been performed suggesting an increase in harm have all used the same data set. Some have used a little bit more. That's why you see a difference in 863 versus 1,000 patients versus 2185. I find it a little bit interesting when I look at this slide that as you include more patients, that hazard ratio starts approaching 1. Look to the right here with the observational data and the one kind of independent randomized data from SWEDPED, that essentially no other data here has ever shown increased mortality. And I think the SAFE-PAD trial here really nails it with 168,553 patients with a median follow-up of 2.72 years, showing no difference in mortality. For me, this trial hammered it home and really definitively put the nail in the coffin on this question of whether or not there's an increase in mortality. Next slide, please. So my take home was drug-coated devices are safe. I still have these discussions. I think you should still document these discussions until the dust settles. But I think this trial, and my hats off to the investigators, there's some fancy techniques, but really the take home here in 168,000 patients that there was no difference in those patients that received drug-coated devices versus not. Thanks so much for the opportunity.
Drew, that was great. I think myself and everybody else in SCAI feels a whole lot smarter after seeing that. Obviously, we'll wait to hear your thoughts about whether the FDA will respond to this, because obviously that's the million-dollar question. So we're going to move on to Gary Ledley from Tower Health in Phoenixville, Pennsylvania. He's going to present RADIANCE Hypertension Trio. Gary?
Oh, thank you, David. I'd like to present briefly now a very exciting study that I think has real clinical implications for the future. And the study is the RADIANCE Hypertension Trio trial, which is an ultrasound renal denervation for hypertension resistant to a triple medication pill. And it's a randomized sham-controlled trial. Next slide. And next slide. The background is this, that endovascular renal denervation has been proven to reduce blood pressure in patients with mild to moderate hypertension. but the blood pressure lowering effect has never been previously demonstrated with confidence in patients with resistant hypertension, which is what we see often in the clinic. The study objective was to investigate whether endovascular ultrasound renal denervation reduces daytime ambulatory systolic blood pressure in patients with hypertension resistant to a standardized fixed dose triple medication pill. Next slide. This is the device. It's the Paradise ultrasound renal denervation system made by Recor Medical. And it is an ultrasound heating device that causes thermal energy. And then there's water cooling to protect the endothelium. It causes a ring of ablative energy, 1 to 6 millimeters deep, to interrupt renal nerve traffic in a circumferential area technique. The arterial wall is protected by the circulating water. And the device is just 2 to 3 sonications of about 7 seconds each, which is automated, and is delivered to each main renal artery. Next slide. This is the algorithm of the study. I think it's very well done, randomized, blinded, with a sham procedure. Patient's entry is on the left. The blood pressure has to be greater than 140/90 in the office. Then on a fixed dose triple combination pill of a thiazide, calcium channel blocker, and an angiotensin II receptor blocker, the ambulatory blood pressure had to be greater than 135/85. There had to be no other causes, no diabetes, and eligible renal artery anatomy. So patients were screened in the office, then they were given the combination pill for 4 weeks. They then had another daytime ambulatory blood pressure screen. They then had their renal artery anatomy assessed, whether they were amenable to renal artery ablation technique. And they were randomized between the real device versus a sham procedure, and then followed up. And this is 2-month data. Next slide. 1,000 patients were looked at. Many did not meet the blood pressure criteria. 100, and some didn't have proper renal angiography on renal anatomy on non-invasive studies. 150 underwent renal angiography. A few didn't meet criteria then. And the resultant 136 were randomized between the sham or the real procedure. Next slide. And the patients were typical patients that we tend to see. Next slide. And next slide. Next slide. And this is what the blood pressure looked like once they were ready after their triple medical therapy. They still had high blood pressure, about 150/93 in both arms. And I think I wanted to show this because this is reflective of what we often see, patients on 3 medications still with significantly elevated blood pressure. Next slide. This is the procedure, and I was one of the investigators in this study who did the procedure. You can see the procedure time. Now, a lot of this was studying and randomizing and waiting, but the procedure time for the real device was about 83 minutes, for the sham, 40 minutes. About 60% had conscious sedation, and we really needed heavy sedation so patients couldn't tell if they really got the real procedure or not the real procedure. 25% had deep conscious sedation with propofol, and 10 to 15% had general anesthesia. Next slide. And this is the endpoint. You can see in green are the renal denervation patients. They had about an 8 millimeter drop in the intention to treat versus 3 millimeter with a sham. And just looking at the patients who really had the entire trial and were available for a 2-month follow-up ambulatory blood pressure, about a 9.7 millimeter drop compared to 3 millimeter in the sham. So I think a very clinically relevant drop in blood pressure. Next slide. This slide shows the reduction in blood pressure in the colored versus black lines. The colored are the patients who had the real procedure versus the sham procedure. And you can see 24-hour reduction in blood pressure from the real device. Next slide. And 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 next slide. The major adverse events, there was one patient who had death from a non-study etiology in the renal denervation arm. And there was one patient who had a pseudoaneurysm from the femoral access site. Next slide. And next slide. And these are the conclusions. And I think it's nice to look at these conclusions and see how would it affect patient care conceivably in the future. In patients with hypertension resistant to guideline recommended triple combination therapy to single pill, ultrasound-based renal artery denervation was associated with a reduction of 8 millimeters in daytime blood pressure versus the Sham control trial. There was a greater blood pressure lowering effect in the randomized denervation arm versus the Sham arm. And the results were concordant with those in the RADIANCE solo arm. And further studies are going to be ongoing as well in the future for follow-up. So thanks for your attention. And when we get to the roundtable discussion, I'd be very happy to answer any questions.
Thanks, Gary. They did a great job presenting that. So to bring us home with our final presentation, we have Kirk Garrett, past SCAI president and present chair of our SCAI Communications Committee, who's going to talk to us about some insights from the ISCHEMIA trial. Kirk?
Well, thanks a lot, David. Let me just bring my slides up if I can. Here we go. And are you seeing my screen in presentation mode yet?
Perfectly.
That's in presentation mode. There we go. All right. Well, thanks everyone for the chance to talk to you a bit about the recent presentations at ACC, looking at analyses of data extracted from the ISCHEMIA trial. The slides and information I'm going to share with you represent data that was presented by Greg Stone from Columbia and Creighton Mavramatis from Emory last week. I'll try to just run through the top level of their presentations quickly for you. They were interested in understanding the impact of complete revascularization on outcomes, both clinical events as well as quality of life measures. And so here's what they did. They got the ISCHEMIA data set, and they said, all right, what we'd like to know is whether or not patients with stable ischemic heart disease get more benefit out of a strategy of complete revascularization as opposed to selective revascularization if they're going to go ahead and get invasive care. They also wanted to know whether or not pursuing complete revascularization, if you were going to undergo invasive care, resulted in substantial additional benefit as opposed to a kind of routine approach compared to patients who got medical therapy. So to do this, they went through two exercises. First, they took those patients who had invasive care, and they divided them into those with complete and those with incomplete revascularization. They used anatomic and functional entry criteria that I'll describe in a moment. Secondly, they looked at those patients in the invasive treatment arm and said, all right, what if we theoretically modeled that all patients in this cohort receive complete revascularization? How would that have impacted the findings of the ISCHEMIA trial? Again, there was a need to define what was meant by complete revascularization. Certainly anatomic complete revascularization is straightforward enough. If you've got a lesion that's more than, say, 50% on QCA in a reasonably sized vessel and that gets treated, we'll say that you had all your significant lesions treated. Of course, functional assessments introduce new variables here. So they defined functional entry criteria and functional complete revascularization to imply that vessels that were reasonably sized and had FFR or IFR measurements that we accept as being significant or denoting ischemia, those were all treated as long as the diameter stenosis was at least 30%. If it was less than 30%, there was an acceptance that there must have been something errant about the measurement. If you had a non-invasive ischemic test and it was localizing ischemia in the distribution of a lesion with at least 50%, or if you had non-localizing severe ischemia, say by an exercise treadmill test, and also had a stenosis that was at least 60%, or if you had by QCA any narrowing that was greater than 70%, you qualified as having a significant lesion and that had to be treated. If all of those were treated, you were considered to have had complete revascularization. It's important to note that, as is true in clinical practice, in the ischemia trial, it was a relative minority of patients who actually got complete revascularization using these criteria. In the anatomic entry group, about 43%. In the functional entry group, about 58% got complete revascularization. And it's also important to remember that folks could have been revascularized using PCI or bypass surgery or a combination of the two. As you might imagine, patients who got complete revascularization were in fact different from patients who did not. There were a number of variables that were linked to the likelihood of your getting complete revascularization. The usual suspects you see on this slide, things like diabetes, a large atheromatous lesion, the presence of left main disease. It's also notable that complete revascularization was associated with patients who got bypass surgery rather than PCI as their first revascularization procedure in the ischemia data set. And so what was found? Well, given everything I've just said to you, you might say, I think complete revascularization, even though being offered perhaps to a sicker cohort, should offer some benefit. And indeed, looking at the unadjusted data set, that's the easy conclusion. In fact, the 4-year delta in clinical outcomes was at least as significant as for the overall trial, overall trial findings. Looking at the primary endpoint, the composite of the 5 clinical events that made up that composite endpoint, you can see that using anatomic or functional entry criteria, the patients who had complete revascularization in the green lines had lower event rates than those with incomplete revascularization. However, the bad news is that when you adjusted for differences between those who did and did not have complete revascularization, adjusting for those variables that we know impact the primary endpoint, the benefits seem to vanish. So that the 30 to 40% relative reduction in events associated with complete revascularization was diminished to an insignificant level after risk factor adjustment. Now, the second part was to look at how complete revascularization impacted, impacted the outcomes relative to patients who are treated with medical therapy. To do this, another fancy statistical tool was used, something called marginal structural modeling. In this, what was done effectively was the patients who had complete revascularization were assessed, and then those who had incomplete revascularization were adjusted, creating a treatment group that you could imagine hypothetically represented a group of people, all of whom had complete revascularization. The findings in that cohort then were compared to those in the ischemia trial who had been treated with an initial conservative care plan. Not surprisingly, that statistical modeling yielded a signal of even greater benefit for an initial invasive strategy than had been seen in the overall trial. And you can see, using anatomic or functional entry criteria, the benefit in the invasive group was greater than it had been for the overall trial. Now, what about the quality of life variables that Creighton was interested in looking at? Essentially, using the same data sets, looking at the functional outcomes rather than the hard clinical outcomes, you can see that there is a tendency toward improved outcomes with complete revascularization. And this seemed particularly true in those who had functional entry criteria to be included in that complete revascularization cohort. You can also see, though, if you look at these forest plots carefully, that the degree of benefit is not robust. There are on certain line items taken out of the Seattle Angina questionnaire, statistically important benefit, but for most of these variables, the benefit is very marginal. What was not surprising was that the greatest benefit was seen for quality of life measures among those patients who had the greatest degree of disability at baseline. And that's concordant with the findings of the trial overall. So those patients who had angina on a daily or weekly basis were most likely to show benefit, and they seem to extract the greatest theoretical benefit from a strategy of complete revascularization. And this was true for both anatomic and functional criteria entry cohorts. Now, switching to that invasive versus conservative care strategy, the modeling that I mentioned, perhaps predictably, a strategy of complete revascularization yielded positive benefits for patients. This was true. These slides are for the invasive entry group, but the same was true for the anatomic group. And in fact, if you compare the degree of benefit for this theoretical model of pursuing complete revascularization with an invasive strategy, you can see that the magnitude of benefit is greater for just about every variable for quality of life that was assessed in the ischemia trial, as compared to a more standard approach in invasive therapy, in which half, roughly, or maybe less of patients receive complete revascularization. And indeed, a strategy of complete revascularization yielded theoretically in this model the greatest degree of freedom from angina of any strategy in the trial. What was a little bit surprising to me was that there was a significant interaction between benefit and baseline degree of angina, but there was not a similar relationship observed between benefit and the degree of baseline ischemia. So if you look at the upper table here, you can see that those that had daily or weekly angina were highly likely to extract a benefit with a strategy of complete revascularization, and that diminished for those who had monthly or no angina. If you go to the bottom table, you'll see that whether you had mild ischemia, moderate ischemia, or severe ischemia, the magnitude of benefit was not very different. Still benefit with complete revascularization over medical therapy, but there did not seem to be a robust relationship between your baseline ischemia and the degree of that benefit. So my takeaways from this very complex analysis is that in stable ischemic heart disease patients with moderate or greater ischemia, both clinical outcomes and symptoms may be reduced with an invasive strategy, and that may be optimized if complete revascularization is achieved. Overall, I think the magnitude of benefit demonstrated in these analyses was relatively small after risk adjustment. Importantly, for symptoms, it was interesting that baseline presence of a large ischemic burden or chronic total occlusions, I didn't show you those data, but that was also true, did not seem to identify the patients who would get special benefit out of a highly aggressive complete revascularization invasive strategy. So those are my takeaways, David, and I'll be happy to turn it back over to you.
Great, Kirk. There's a lot of provocative questions in there. So we've gone through our presentations. Let's just do a quick roundtable, and I'll just ask each of you one question. If anybody has a follow-up question, go ahead and chime in. The hour's late, so we're going to be fairly concise here. So, Luai, I guess the question I had as I went through your presentation, we're not going to get another clinical trial, right? Because TWILIGHT was a pretty big definitive study. So I would love to hear your thoughts about, do we have enough data to tell our female stent patients that we can come off of aspirin after 3 months of DAPT and just continue TICAG?
I think we can say that in a high-risk population that it's certainly something we should consider. At least compared to men, we can't definitively say that, all things equal, there is any difference there. And we'll probably get more data. I think longer term follow-up will probably an important thing to think about. And I think if we can show that safety continues in long-term follow-up, yes, we can.
What are you doing in your own clinical practice right now?
For the most part, I'm starting to shorten my DAPT. I know I'm used to doing 12+ months, and now I'm leaning towards shorter DAPT, especially in high-risk populations, given all the data that we are looking at.
Yeah, I think that's
global leaders and others.
Yeah, that's what I found provocative about TWILIGHT. It wasn't an enriched high-risk group of patients here. These weren't type A lesions. So, okay, thank you very, very much, Laura. Mike, I think the $1 million question, you really hit a lot of summary points, but is this study, Flower MI, going to change guidelines? I sort of practice like you do, and I think the guidelines pretty much say that. If it's greater than 70%, you get a pass on going ahead and doing your intervention. If it's less than 70%, you got to prove ischemia with either FFR or nuclear scan. What does this study suggest the guideline committee ought to change, Mike?
You're muted, Mike.
Thank you. I was just trying to save everybody some pain. So David, I think my speculation would be that the Flower MI trial may not be enough to move the needle to make angiographic guidance only the preferred criteria for STEMI patients. I think it probably warrants changing it to a 2A type of recommendation, that angiographic guidance, at least in the context of that trial, was equally up to the task with FFR guidance. My own personal practice, I don't think is going to change. I think I'll continue to be liberal in complete revascularization of angiographically severe lesions, but still selectively have a hybrid approach and still use FFR for those patients with more intermediate and less severe lesions.
Mike, I really found it intriguing that they didn't do it. They didn't do the second non-culprit vessel at the same time. You mentioned 95% got staged. Do you think it matters whether or not you do it during the index hospitalization or you bring it back a couple weeks later? What do you do in your own practice?
So I think the complete trial has good data on that. Which showing that you don't lose a lot by waiting a few weeks. There was no difference in those with in-hospital complete revascularization versus those that were staged at a later time. So my own practice, David, really depends upon a lot of how large the infarct was. If it's a huge infarction, where I think there's a benefit of allowing some recovery of myocardium before putting another territory at risk, particularly if it's not a kind of a subtotal non-culprit lesion. In those type of patients, I may wait a few weeks and bring them back. If it's an early culprit lesion revascularization, LV function is not severely impaired, and we had a really good result on the culprit lesion, for convenience, we'll often take care of that before the patient goes home.
Perfect. Thanks, Mike. Okay, Drew, boy, I'll tell you, I think one of interventional cardiology's finest moments is to respond to the initial analysis that I think frightened everybody. So the two questions for you, Drew, are, is the game over? Is this safe PAD the final word? And what do you speculate about the FDA response will be?
So for me personally, I think, I agree with you. There was a lot of response across SCAI to this, and I think we should be proud of our response with the SCAI leadership to really respond to the call for is there harm or not. I think we have great guidance on our website, and I do stress probably getting a copy of that. And if you have a question, please go into the website and getting that response until the dust settles. I think the FDA is going to have to do some serious thinking about this. For me, 168,000 patients kind of tells me what it is. I'm old enough to have lived through the Swedish SCAR registry. You remember in 2007 with that big sign of stents kill. I remember those years, and I sense we're going to see a swing back. DCB skill, and now we're going to kind of come back to say, maybe that data is not real. So I think we're going to see that happen here with DCBs. For me, I think this is the nail in the coffin to say that it's a safe therapy. Personally, myself, I've not stopped using them for my patients that are high risk. For our patients that are TASC-A and can be treated with regular non-drug coated, I just use non-drug coated, and that's more of a cost issue than anything else. I look forward to see the FDA's approach to this. I think they're going to have to really think about maybe perhaps consider modifying that response. I think it's always a good idea to going over informed consent, no matter what it is. And if there's been a signal, I think it's always good to document it. And so for me, I would say it's not going to change what I do. Even if the A goes back 180 degrees, I'm still going to probably still document that discussion just because I think it's important to talk about things when it comes up.
Well, great. I'll ask you a quick question, Drew. Do you think the documentation that you've been a leader on is an individual documentation, or should the cath lab require that operators doing DCBs have the documentation of the consent that you outlined?
So I think it's an individual. I don't think you can expect the cath lab to do it because there's too much variability. I think we had talked about this, like, do you change and modify the consent forms? Do you talk about changing the consent forms for your hospital? And no, there's been a lot of talk back and forth about this. And when I at least go through all the, how do you, manage lawsuits and how do you deal with that from the SCAI educational series and professional development, it's really about informed consent. And at the end of the day, if you discuss it with the patient, I think it's there. I don't think you need to bring it to a system level when it comes to this. We didn't do that with drug-coated stents, I don't believe, back in the day when that whole SCAR registry came out. And I don't think we need to do that today.
Great. Thanks, Drew. Appreciate your efforts. Gary, boy, I'll tell you, what a fantastic trial. So the questions for you would be, how important is it to do the sham piece of these trials? And what's the next steps? And what kind of blood pressure improvement should we expect? I sort of want to get a 20 millimeter blood pressure improvement. So if you could focus on those, let us know your thoughts.
Yeah, those are excellent questions, David, and it'll be great to see. I think the technology is very exciting, that you really do get renal denervation. And I think that the idea of having a sham procedure is super important. Interestingly, there were a couple of millimeter drop in blood pressure with just the sham procedure. So I think the fact that we have a device versus a sham really proves its effectiveness. Clinical trials are difficult because in clinical trials, patients are much more compliant than they are just in real practice. So that I think that in real life, one would expect an even greater reduction in blood pressure from taking patients who may not be so compliant with the triple therapy versus the real denervation. So, of course, we would really like, a 20, 30 millimeter reduction, and we didn't get that in this trial. So I think this is real. I think it's a good 10, 15 millimeter reduction with the therapy. And I think the clinical utility will be greater in the real world than it was in a trial where patients were falsely compliant in the sham arm.
Great. So what do you think the next steps are?
Well, I think we need to see if this is durable. And I think the RADIANCE hypertensive trial will be looking at patients 6 months, 1 year, 2 years, and 3 years later. And I think it's very exciting. So we'll see how it goes for durability.
Well, great, thanks. I know you've been a real leader in this area, and we look forward to your presence and teaching us more about it, Gary. Thanks. Kirk, we'll turn to you. Boy, there's a lot in there. I guess two quick questions. One, angina versus ischemia. Boy, it really seems to be the million-dollar question. And the sort of provocative question is this all statistical Houdiniism? I'm not sure I understand what marginal structural whatever it was is, but is this relevant to the patients I take care of?
Yeah, I think those are fair questions, David. You know, these modeling exercises I think are really helpful for trying to gather insight into what a perfect practice would look like. But of course, we're never going to achieve complete revascularization in 100% of our interventional patients. Remembering too that much of the complete revascularization was achieved through bypass surgery. So for the interventionalist, this has even a more dilute message. My takeaway though is that if I can in fact safely achieve complete revascularization in someone who I'm taking to the cath lab for stable ischemic heart disease, there's enough here for me to feel comfortable that I'm not doing something mad. There was no signal of harm associated with that strategy. There was a signal of potential benefit. How do you unhook the ischemia from the angina thing? I don't know. That sort of is really difficult for me to explain. But you know, the data are what they are. This is what we have. I think it's probable that ischemia will stand as the largest stable ischemic heart disease population under study for this purpose for a long time, maybe forever. So we have to do the best with what we've got.
Thanks, Kirk. I think that really nails it. You know, we're not going to get another trial like this in a long, long time, if ever. And so we just have to parse it out and keep doing what we think is the right thing for the patients. So if there's no other questions, anybody from the panel have any other questions to each other that I might have missed? Well, if not, I'm going to thank Luai, Michael, Drew, Gary, Kirk, and of course, Kim for her wonderful work to make these happen. Thanks a lot, guys. I hope we got a lot out of this. Take care.
Thank you.
Thanks so much, David.
Thank you, everyone.